Hello everyone, and welcome back. Sometimes patients present with a combination of aortic valve disease and coronary artery disease. That essentially mandates this to be done as a sternotomy to do concomitant aortic valve replacement and coronary bypass grafting. In this first case, we developed a new technique to approach grafting of the left internal mammary artery to the left anterior descending, all done through a single incision through the same transaxillary approach, where we did aortic valve replacement and coronary bypass grafting using the left internal thoracic artery to the left anterior descending. Let's have a look. To follow along the theme of use of this as a platform, we now show a case of combining robotic aortic valve replacement with coronary bypass grafting. Historically, robotic minimally invasive direct coronary bypass grafting, or mid-CAB, or totally endoscopic coronary bypass grafting, or TCAB, has been established through left chest approaches, grafting a stenosed left anterior descending artery with a left internal thoracic artery. Now, the robotic approach for robotic AVR has been performed all through a single incision minimally invasive right thoracotomy laterally. We now combine these techniques, all done through a single right lateral incision. So let's review. This outlines the procedure, again, through a right transaxillary incision, identical to the RAVR platform, as well as mitral surgery. Port placement also identical, with the arm 1 being the DeBakey, and at the time of the coronary grafting, we utilized the microbipolar forceps, particularly with the Lita harvests, as well as the performance of the coronary bypass grafting. The camera is placed through arm 2. For the vast majority, it is 30-degree up like usual for all of the robotic operations, but we utilize the 30-degree down for the time of the distal anastomosis, which we'll describe in a moment. Arm 3 is the long tip forceps, as we use for RAVR, and then exchange for the pot scissors when necessary for the coronary and the Lita harvest. And in arm 4, we have the needle driver, but also the spatula when it comes for the Lita harvest, as well as a small clip applier and black diamond forceps. The skeletonized Lita harvest was performed using a microbipolar, as well as spatula, and then the clip and cut with the clip appliers. Now, this is an important step. The left pericardial marsupialization. For the experienced surgeons, we performed off-pump bypass grafting utilizing this type of technique through a sternotomy. We applied these maneuvers carefully after some efforts in the lab to experiment to make sure we can do this safely. And after being able to perform this, this was done through a tacking suture to rotate the heart axially to enhance exposure of the left coronary system, all done through the right incision. We will go through this in a moment. And the RAVR itself is performed as we've already described, but the coronary grafting is done uniquely a little bit compared to TCAB in that we utilize the tableside assist directly in the anastomosis, which helps facilitate. Now, the patient we're going to describe is a 73-year-old, fairly frail woman with a BMI of only 17, with a long-standing smoking history, chronic obstructive pulmonary disease, who had suffered a stroke 1 year prior to admission, but also a fall and a subdural hematoma 8 months prior that required a craniotomy, leaving her with a small residual left deficit, pupilar dysfunction. And while being quite frail, she was functional and living independently, thus making her a surgical candidate. She had symptomatic aortic regurgitation, class 3 heart failure, and pre-syncopal symptoms, with an LAD noted to be at 70+% stenosed and ejection fraction of 35%. For AVR CABG in her situation, her STS predicted risk of mortality was 10%. So she was recommended for AVR CABG. I personally recommended this to her, but the patient and family and her referring cardiology colleagues, as well as a heart team assessment, thought she would not tolerate a sternotomy very well. And given her anatomy, she was not really amenable to a percutaneous option, particularly for her aortic valve, at least in the current state. Therefore, all requested a non-sternotomy option consideration. To determine if she could get a little better, we attempted guideline-directed medical therapy for 6 weeks, but this did not improve her symptoms or her aortic insufficiency, and her ejection fraction remained at 35%. Therefore, after full informed consent with all disclosures noted, the patient and family agreed to proceed with a robotic approach. So if we have a look at the echo, we can see the lack of coaptation of the leaflets with severe aortic insufficiency. There's rolled edges, potentially a rheumatic etiology with severe aortic insufficiency, her somewhat depressed ejection fraction, cath revealing this proximal LAD stenosis. So we proceeded with a single right transaxillary incision, and these are the spatulas for blunt dissection after sharp electrocautery dissection to expose the leta, and then clipping and cutting and usual techniques to perform a skeletonized mammary artery harvest, heparinization, stapling the leta, and now proceeding with the robotic aortic valve aspect of the procedure. So the valve is exposed. As you know, there is severe aortic insufficiency, so coronary ostial myocardial protection was utilized. The leaflets you can see inspected. They were first excised. Minimal calcium here, as you can see. And these were removed. The annular sutures were then placed, as we have demonstrated in other cases. Again, switch to the left hand at around the noon on the clock face, then back to the right hand for the completion of the sutures. And now we deliver a 23 millimeter bioprosthesis and provide suture fastening to complete the bioprosthetic RAVR, confirming nice location, and then closing the aortotomy in our standard fashion using 2 layers of 4O polypropylene suture. Once again, as we've demonstrated in other cases, and the completion of the aortotomy. And following this, of course, we will deliver antegrade cardioplegia to now set up for the distal anastomosis. And in order to do that, we have to expose the anterior heart, and particularly the left side. So we'll utilize a braided suture, of course, being careful to avoid the phrenic. And so 1 stitch below, 1 stitch above, and then tacking against the chest wall to provide some counter traction. And this ability then allows us to do axial rotation of the left side of the heart. This is the 2nd stitch placed, and now we can start to see the left anterior descending quite nicely. Some sharp dissection to expose its surface. Traction sutures of 5O polypropylene, as you can see, set up again with some tacking to the chest wall, and then a small silastic to gently provide proximal occlusion to facilitate a sharp entry with a sharp point knife, followed by exposure. This is where we flipped to the 30-degree down to facilitate this portion. And then we'll proceed with a side-to-side distal anastomosis, just to allow the weight of the clip to help expose. And then following TCAB techniques to perform a direct coronary anastomosis. One unique thing about this situation, since we have the working incision, that my colleague, Dr. Wei, was able to follow the suture to aid in the facilitation of this distal anastomosis, which is slightly different than the true TCAB method. In fact, the total anastomotic time was 27 minutes, intracorporeal tying, allowing the vessel to now be set up. A clip for the distal end. And here's the final anastomosis. Heart was reanimated, and we can see the aortic valve functioning very nicely, and the ejection fraction already improved on low-dose inotropic support. And the patient was weaned from cardiopulmonary bypass and transferred to the intensive care unit. She was extubated 4 hours postoperatively and continued to do quite well, and was actually discharged home directly and on room air and ambulatory with an ejection fraction upon discharge of 50%. So here we see how we can utilize this robotic AVR platform to perform concomitant robotic AVR along with coronary bypass grafting. So now you've seen our approach to concomitant aortic valve replacement and left anterior descending grafting with the left internal thoracic artery, or RAV-CAB. But this can also happen with mitral valve disease using the similar techniques. What we're sharing with you that I hope you take away is the accumulation of knowledge and techniques that you can take home to apply to patients that may not be an ideal candidate for a sternotomy or that would like another option. I just want you to make sure we always pursue safety and quality first. What I hope you've seen is that robotic heart surgery is no longer one procedure, but this transaxillary approach potentially is the pathway to perform all of heart surgery done robotically. I hope you take this information to improve your practice, develop your institution and your team, perhaps for your region, your state, maybe even your country. But in the end, there's only one most important element, and that's to improve the care, the safety, and quality of your patients. My best wishes to you. Thank you for joining us.